patient, a recent H&P has been performed. I've already performed my machine checklist with my suction at the bedside. My airway equipment is laid out on the anesthesia machine. My induction drugs and emergence drugs are laid out on the cart, as well as my emergency medications already drawn up.
You just want to get your machine was checked, right?
Yes, machine check with the suction,
Okay.
and then with the machine check, also the vaporizers are full. Hello.
I see you've got gloves on.
Oh yes, I got my protective equipment on: booties, gloves, mask, hair cover, and surgical scrub attire is on. And I'm sterile. Did my hand washing before I came in.
Is there anything else in the PPEs that you should have?
Mask, eyes, well, mask, face shield, hair.
So your eyes are protected?
Eyes are protected.
Okay.
Yes. Face shield. Hello, sir. My name is Dallas. Do you remember me from the pre-op area? I was your nurse anesthetist. Did the assessment on you. How are you feeling right now?
I didn't tell you this is Katie. And
Okay.
she's 70 kilos.
70
Doesn't
kilograms.
have gallbladder. No history of any medical problems.
Okay.
She's a healthy lady. She's like 45 years old.
And no known allergies? Okay, Katie, I'm going to just put this pulse oximetry on your finger, and we will measure your oxygen on room air. Also, I'm going to place these little electrodes on you, and I'm going to put this blood pressure cuff on you. So I got blood pressure, I got an oxygen reading on room air. And then also, I'm going to make sure her IV is patent, not expired, and working and fusing. And it's clear, no wires are tangled up on my IV. And of course, blood pressure cuff on the opposite side, not including the IV or the pulse oximetry. So Katie, how are you feeling right now?
I'm scared.
You're scared? Okay, well I can do something about that. I'm going to put this mask on your face with 10 liters of oxygen, and we will pre-oxygenate your lungs, get your lungs nice and filled up with oxygen. And I'm also going to give you some medication to help you relax. This is called Versed, and it's going to help you relax. So I'm going to give 2 milligrams IV push of midazolam. Also, two milligrams of IV push of midazolam given. I'm also going to give you some pain medication, Katie. This is fentanyl, and I'm going to give 2 mils, which is 100 mics of fentanyl IV push. All right, Katie, how do you feel?
I feel better.
You feel better? Yeah? Take some deep breaths for me. Nice, big deep breaths. Good. I'm gonna assess her level of consciousness, kind of see where that midazolam fentanyl combination has put her. You ready for your surgery? Are you from the Springfield area? I'm just trying to see how sleepy she is to assess if I need
I'm
propofol.
from Kansas City.
Oh, Kansas City.
I'm a Royals fan.
All right, Royals fan. So I'm going to go ahead and give propofol. And she is a 70 kilogram woman. But before I give the propofol, I'm going to give the lidocaine, which is cardioprotective and will help with the skimming of the propofol, IV infusion. So 70 milligrams. Lidocaine is 1 mil per kilogram. So I'm going to give 7 mils, 70. I'm sorry. I'm going to give 7 mils, 70 milligrams, but normally we give 100.
So you're giving 70 to her?
Yes, sir.
Okay.
Not normally, but I'm just saying maybe let's see some. Okay. So here's lidocaine. 7 mils, 7 milligrams.
I think the stock car is closed.
Oh, it was. So let me. Oops, I turned it. There's 7 mils. open towards me. Okay. Lidocaine. Given. And propofol is 1 to 2.5 milligrams per kilogram. She's 70 kilograms. Because we can always give more, I'm gonna start with 1 and assess. So 7 milligrams, 7 mils, 1, 1. Propofol.
How many milligrams are you saying?
7 mils, 70 milligrams for 1 to 1. The range being 1 to 2.5 milligrams per kilogram.
And just to add in here, you wouldn't really squirt out propofol because
Okay.
you may need to give the
More.
rest of it later on.
Yes.
Okay, go ahead.
Just to keep it simple for myself. So, Katie, can you take some deep breaths for me?
Turn your stop cut back. She responded to you?
Eyes are still blinking, but not talking. Okay, she is asleep. So first thing, I'm going to create my C-seal, and I'm going to pad Katie and make sure that I have an airway. Getting the feel.
Airway good?
I have an airway. Okay. So now I'm going to go with a neuromuscular blocker, sucks or rocuronium, sucks being.
And you're doing a gallbladder that's gonna last, say, an hour, so.
So an hour is the duration of rocuronium. So rocuronium, which is 0.6 to 1.2 milligrams per kilogram. But then Tracy told me that we never give more than 50 milligrams, 5 mils. So here's a 5 mil syringe.
So you give her maybe 50 milligrams?
Yes.
But just say you're gonna give her, just give her 10 milligrams of that.
10 milligrams.
Otherwise, they'll be paralyzed for a long time. So just give her 1 cc of that. You don't have to squirt it out.
Sorry. One mil, 10
So,
milligrams
yeah.
of rocuronium infusing given. Onset time being 1 minute. So by the time I get my airway equipment, she should be good to go. Equipment ready.
The stopcock was closed.
Oh, sorry. Rocuronium, 10 milligrams, 1 mil infusing.
Why don't you get just a teeny bit of it?
Just a
Just
small.
don't keep reading.
Okay,
Just give a little bit. Half cc.
half cc. Half cc.
And you stop.
Still says it was closed.
Sorry.
Is it right?
Still saying closed. So it must be, I don't know.
Yeah. Go ahead.
Okay, she's awake now. So I'm gonna give some more propofol.
Okay.
I'm scared.
Okay. I'll help you with that. Should have put it out.
What else could you do to keep her asleep? And you've got her asleep now, so what other agents do you have in the room that you could be using on her?
Nitrous.
Or turn on your seatbelt?
Turn on seatbelt.
Yeah. Go ahead, you can go ahead and give her that. There's nothing wrong, that's what I would do. Her eyes were opening up. But as you're progressing through your induction here, as long as your pressure's okay, you can go ahead and crack on your SIVO to 1%, work your way up or whatever.
Gotcha, even though she's still facing.
As long as you can ventilate her, then go ahead and crack it on your SIVO is a good way to keep her asleep.
So here's another 70 milligrams, 7 mils of propofol. And then stopcock towards the syringe, my finger out of the way. Green light says okay. It's kind of off and on. There it goes.
That's kind of hard to push. Let's go ahead.
Even though the green light's not on, it's kind of.
Good. Do we read?
Katie, how you feel? Eyelash flick. No response.
Okay.
Okay, paralytic is on. So I'm going to go ahead and intubate. Another 7 mils, 70 milligrams.
Okay. And what do you want to do before you intubate?
My airway is.
Did you already use muscle relaxant?
Yeah, I gave the when I was given. Oh, well, it never registered, so you want me
Okay, so
to.
you're okay.
I put it in.
Okay, but I did
It's
give
in
the.
there.
Yeah. Okay.
Good.
Okay, I visualize the cords. Visualize the tube going through the cords. Keep my hand on the tube. Okay. Got condensation. I visualize the cords. Chest rise. And I need at least 3 breaths because even though I can be in the esophagus with 3 cycles, and that's a perfect waveform. And
You told me condensation, you saw the tube go through the pores.
and then auscultation, condensation,
Okay.
and now I'm gonna listen. Have breath sound,
Okay.
and my CO2 waveform is perfect.
And you have CO2 waveform?
Yes. So now I'm going to bag the patient, and as I'm bagging, I'm assessing to make sure that I get tidal volume of what I want, which is 600, and there's no resistance as I'm bagging, so the patient's still asleep.
How deep were you on the tube?
Oh, 23 at the teeth.
Okay.
And now that I feel like the tube's in place, patient is asleep, my airway's good, I'm going to go ahead and tape the tube, and I'm going to tape the eyes,
Okay.
and I'm going to turn on my SIVO at 2,
SIVO to 2.
and I'm going to turn my ventilator on. I want to assess to make sure my bellows reaches 600, which is what my tidal volume set, and also want to look on the monitor.
Okay.
And again, my CO2 is 37,
Good.
600 on the bellows, 702 on the 600.
So she's having an abdominal procedure, and you ventilated her before you did your intubation. Is there anything you want to do before they start down here?
Yes, right before incision, I want to give extra pain medication because that's the most stimulating thing we do besides the intubation is the surgical incision. So I want to pre-medicate the patient.
Okay. And since you were ventilating by hand, it's very possible you got some air in the stomach.
So I want to place an NG tube.
Okay.
I want to decompress the stomach.
Okay.
So NG tube to LIS.
So everything's going good. What are you going to be looking for?
Now that I'm in the maintenance stage, I want to assess for vital signs. I want to make sure my patient's comfortable as far as adequate pain. I want to make sure they're still paralyzed. And I want to make sure the position, no pressure sores. Already said my twitches, pain, position. I want to make sure that antibiotics are given, blood if needed, anything that needs to be given is given. Also monitor my maintenance as far as my fluids and keep my fluid balance appropriate balance.
Good. So everything's gone good. The surgery's actually getting done. They're beginning to close.
Okay, first thing I want to turn off my gas. Now that they're starting to close, I want to go ahead and give some Zofran.
Okay.
I want to assess for twitches.
How much Zofran do you get?
4 milligrams, which is 2 mils? 4 milligrams in the vial.
Okay.
But I
She'll get
can't.
it for you. We don't have it in here, so
Okay.
give them Zofran.
4 milligrams IV push.
Okay.
I want to assess for twitches because I want to reverse the patient.
What do you have?
I did not see a twitch, which means at time I'll have to wait.
So when can you safely reverse somebody?
When they have at least 2 twitches.
Okay.
1 twitch, 2 twitch.
Okay. If they have no twitches, you should not consider reversing.
I just need
So
to
you
wait.
want to wait it out. That could be staying in here for a little while, or it could be some worst case scenario, you gave a huge dose of muscle relaxant, the case ended really quick, you have to take them to the recovery room, you put them on a wake-up vent. Let's say that they've got 2 twitches.
Okay, 2 twitches. I want to give neostigmine and glycopyrrolate.
Okay.
Neostigmine is 5 milligrams, 1:1, glyco 0.2 per mil, 5 mils, 5 and 5, heart rate.
Okay. And you do that, and let's say you've turned off your SIBO, right? You tell me?
Yes.
Okay.
And probably turn up my rate a little bit, help breathe it off.
Okay, good. So you're on 100% oxygen now, okay, and you've reversed your muscle relaxant. How do you know it's reversed?
With the wake up, that's the ulnar nerve. Induction is the facial nerve, and I have all 4 twitches on the ulnar nerve. Patient also does a head lift, which would mean 50% of the receptors are occupied, and is actually trying to swallow the tube, and is talking around the tube, and is nodding their head and blinking appropriately. Blink 3 times if you want the tube out. 3 blinks. Lift your head up. Good job. They lifted their head to the chin.
All right.
So, pain medication. I gave some fentanyl. I reversed the patient. I turned off my gas. Now it's time to extubate. So, an indicator for pain is respiratory. So I want to bag the patient and go ahead and take some deep breaths for me. I want to see that they can pull some.
Okay. Is he doing anything for you right now? He's not, but you're right.
And then
when you
CO2.
take him off of the vent, sometimes you want to take him off the vent, let their CO2 rise a little bit, so that'd be the stimulus.
To breathe.
To start breathing.
Mhm.
So let's just say he is breathing right now.
Okay.
What's the sequence of you extubating?
Okay, so I want to, I'm suctioning,
Okay.
okay, and get my 10 mil syringe back on, ready to, when I extubate, I want to extubate with positive pressure.
Okay.
So I want to deflate the cuff. And, all right, we'll get that tube out here in 1 second, Katie. Okay, put it in my little face mask, my syringe. Okay, big breath on 3 on 2. Positive pressure, and then a suction. Cough, cough, cough. Good job, good job. Take it off. And put back on the mask. All right. All right. So I want to just, help the patient breathe a little bit. Take some deep breaths for me, Katie. And I want to assess, what she's pulling on her CO2 and her tidal volume. And assist her.
She's breathing now on her own.
All right.
You got
So.
CO2 up there.
Mm-hmm.
Okay. So let's say you've taken her to the recovery room.
I want to keep the pulse ox on. The first thing I say is the most important thing in the surgery. As I transport her down the hallway, keep my hand on her face or on the face mask, kind of make sure I can still feel breaths moving as I transport her. Equipment, ambu bag, or that thing that I can't remember what it's called that they train.
And what are you going to include in your report?
A report, I'll say what I gave.
As soon as he gets through reporting, he can. What's your report?
The most important thing first, medications given, the procedure, the doctor, blood loss, fluids given, antibiotics given, allergies.
Are we almost ready to start my case?
So you got to go to OB.
No.
I got an epidural too.
All righty.
When are we going to start?
Oh, we're already done, darling. You did great. You're
Oh,
awesome.
thank you.
Also, sorry, I forgot to ask you
You're
if
the
you were
best
cold.
anesthetist I've ever had.
No, I forgot to ask you if you were cold.